Okay, everybody, welcome to our monthly Global Health Lecture. As everybody knows, we've been doing this series for the better part of 2 years now, actually. I think we're into our second year. So thank you, everybody, for joining us. Keep your eyes open for future lectures. We try to make sure we send out those announcements, and everybody should hopefully is on the email list. I am keeping up a separate email list, which if you put your name over there when you sign in, if you put your email there, I'll add you to the separate email list as well. And of course, thanks to Delaware Academy and Tim Gibbs for helping us in the promotion. We have been working on recording. I know some people are asking after our last lecture about getting the recording of it, and we do have it recorded. We just are having some technical difficulties on getting it posted, so we will let you know once that is ready and posted. So we're again recording this lecture, and hopefully we'll have it posted soon. So I would like to introduce our speaker tonight. It's my pleasure to introduce Dr. Stephen Epps, and I know some people in the room know Steve from his involvement in the infectious disease community. Steve worked for a number of years at AI DuPont as an infectious disease consultant there, and we have the pleasure of having him join our staff now at Christiana about a year ago, right?
July.
Yeah, okay. So not even a year ago. So Steve is going to help us learn more about global health, and in this case, like we talk about often, sometimes global health comes to us, and it's not always about us traveling, but it's sometimes about our patients coming here. And so without any further introduction, I'd like to bring up Steve Epps, who is going to give us his lecture from Ethiopia with love.
Is it possible to get the front right? Can I just a little bit? How's that?
I don't know, but we'll figure it out.
Okay. Thank you, John. It's a pleasure to be addressing all of you tonight. Ooh, that's dangerous. Now, a lot of these people are former residents. I've watched them fall asleep on me before. All right. Like John said, first of all, caveat, and I told John this, I don't hold myself out to be a global health expert at all. You might recognize this guy right here. We've been to Haiti a couple of times, haven't we? But in this case, it's like John said, the global health came to us. What I will try to cover tonight is a little bit about Ethiopia, our patient, sweet little girl that I cared for a number of years. Talk about HIV/AIDS in Africa in particular, and opportunistic infections in Africa. So here is a map showing the global distribution of HIV and AIDS. We'll talk more about this as it's going, but our story is centering around right there. I've never been to Ethiopia. I did read a book about it once. I compiled a little enough information for you. I thought no talk like this would be complete without something like that. So a little travel log. It's an interesting place, actually. It is the birthplace of human beings. Homo sapiens, all of us, had our start in Ethiopia, and then we migrated to different parts of the world. The actual nation, Ethiopia, is probably about 3,000 years old. It's mentioned in the Iliad and the Odyssey, for example, and the name was very similar to Ethiopia. During most of this time, it was a monarchy, and in the early part of the first millennium, it was a major world power. It was the first state, first empire to adopt Christianity as the national religion, believe it or not. It was known for centuries as Abyssinia, which is another take on the name Ethiopia. And in general, in recent history, in the 1670s, 1800s, it was one of the more progressive of the African nations. Modern Ethiopia dates to about 1868. Tawadros, translated Theodore, was actually a drunken maniac, but he helped to organize the country politically and socially, and the borders that are drawn on the map are mostly due to his efforts. It was the first African country to join the League of Nations after World War I, which really tore up this part of the world, as you may know, and it also was one of the first to join the United Nations. Unfortunately, in around 1970, a communist regime came to power. Things kind of fell apart for about 2 decades under that regime. More recently, we have a, quote, democratically elected government, which I'll tell you a bit more about. Physically, it's quite diverse. It's not Saharan, so it's not sand land. It's really a lot of different geographical and topographical features, including highlands and mountains and lowland steppes. It's the source of the Blue Nile. Mostly a tropical climate, but in the higher elevations it's more arid. Unfortunately, and partly during this communist regime, there was massive deforestation causing erosion and all kinds of other problems. So here are some pictures that I just took from the internet showing some really pretty spectacular views of the highlands. And there's all these geothermal phenomena that are throughout the country as well. It's home to about 93 million people currently. Officially, it is a federal parliamentary republic, although it is more of an authoritarian regime. The democracy index ranked at 118th out of 167 nations. So even though they say democratic, not so much. In terms of religion, it's mostly Christian, 63%, and 34% Islamic, and just a couple of percent of more traditional tribal religions. There are 90 languages spoken, none of them spoken by a majority, maybe 35% for a couple of big ones. And in terms of medical issues and outcomes, the life expectancy is short. It's about 58 years. Infant mortality is one of the highest in the world, 8%. And there are 2 medical doctors per 100,000 people. Not good. Here is an aerial view of the capital, Addis Ababa, which is a metropolis of now about 3 million. And a lot of that growth has occurred in the last 20 or 30 years. And with a lot of poor countries, as you probably know, urbanization has been common. People leave their agrarian roots and come into the cities where it then becomes more crowded and less safe and less sanitary and so forth. The people are also diverse. So in the more northern areas, you have a more Arab-looking population. In the southern areas, you have a more traditional black African population. The economy in recent years has improved. It's one of the only regional countries that is not oil dependent. It's mostly agricultural, and its #1 crop is coffee. Raise your hand if you drink coffee. Coffee actually originated in Ethiopia, so you can think about that the next time you have a cup. Gold accounts for 7% of the exports, but it's still one of the poorest countries in the world. Human rights is a major issue. The State Department of the United States said it remains poor, although there were improvements, serious problems remain. I just found these factoids for you. 69% of marriages are by forced abduction. Malformed infants are disposed of without any kind of proper burial. Female genital mutilation is a widespread practice. Human trafficking, mostly of children, is common, and police brutality is common as well. So on this backdrop, we have this wonderful family from Newcastle, Delaware, suburban area, nice family, successful businessman. Wife was a former nurse, now a stay-at-home mother. They have 4 children of their own, but they decided they wanted to go to Africa and find and adopt a child with HIV/AIDS. So they left in November of 2007, had to stay in Addis Ababa for about a month, where they did all the regulatory stuff, and adopting kids from another country is a lot of rigmarole. During that time, they got to know their daughter a little bit, and they finally made it back to the good old US of A on December 1st, 2007. Anybody know what's special about that date? It's World AIDS Day, December 1st. So it's complete coincidence that they arrived back that day, but maybe it has some meaning, I don't know. And they came to see me, I think the next day, December 2nd. So let me tell you her story. About 2 weeks before I saw her, and the family was already involved at this point, this girl had a febrile illness. They described her as having high fevers and lethargy. She didn't have any respiratory or GI symptoms. She did have a rash that was quite noticeable, and they thought that was there before the fever occurred. Note that her date of birth is given as 10/6/05. That probably isn't accurate. So she had been treated for this febrile illness by a local physician in Addis Ababa with 5 daily injections for a diagnosis of typhus. So I actually had to do a little digging on what the heck were they doing, because we give something like doxycycline for typhus. But actually they had given her ceftriaxone. And later on I became aware that ceftriaxone overuse in Africa is really common. For example, if you have a UTI, E. coli UTI in parts of Africa, 25% chance it will be resistant to ceftriaxone, which is much more than we have in the United States. Anyway, but I digress. But she seemed to get better after those injections, afebrile for a few days, but then got febrile again, no particular pattern. In terms of her past medical history, we didn't know a lot. Didn't even know when she was born, to tell you the truth. The orphanage, as is common in developing countries, did not acknowledge that she had any serious problem. They did acknowledge that she had HIV. She had developmental delay, she had failure to thrive. Her immunizations were current, if you can believe the documentation. I say current according to World Health Organization standards. So she'd had BCG and DTP and polio and measles. Just as a pearl, if you ever encounter a child from an orphanage overseas, take those records with a grain of salt. They're often fraudulent, faked. The orphanage, knowing that she was going to be adopted, had performed some blood tests, including an HIV viral load, which was 373,000. Her CD4 was 774. Now, you might look at that and say, oh, that's pretty good. But for a child not even 2, that's too low. We want it to be at least 1,000 to consider it normal. So 774 with 19% is at risk for opportunistic infections. RPR and hepatitis studies were negative, and they had started her on Bactrim prophylaxis, we think. Her family history, we just knew a couple of things. Her father had died a violent death. Her mother had died when she was younger from what was called pyogenic meningitis. I actually got a copy. We were trying to figure out what was going on with this kid. I got a copy of the mother's death certificate, and it was about as useful as the immunization records. But we did find out the mother had been treated for tuberculosis at the time she died of pyogenic meningitis. So this orphanage was in Addis Ababa, which is depicted on the slide. So we knew that she was exposed to things that were in that environment, and I'll go over some of that in a minute. In terms of her dietary history, all that we knew is that she preferred starchy foods. I was going after some unusual exposures like raw milk, thinking things like brucella, but couldn't get any history like that. So being an infectious disease nerd, I was thinking about all the things that you could get in Addis Ababa that would perhaps cause a febrile illness in this particular host, which was a young girl with HIV infection. So here's a partial list. So tuberculosis, well, we know it's endemic in that part of the world, right? Mother supposedly had it. Typhoid, oh, by the way, I put out an article, it was just published this month by one of our pediatric residents talking about fever in a returning traveler, if you're interested. Typhoid fever is one of the most common diagnoses in a returning traveler with fever, especially from India, but also from other parts of the world. Meningococcal disease, well, if you know the meningitis belt of Africa, it's more sub-Saharan, but probably includes Ethiopia, and we knew that the mother of the patient supposedly died of pyogenic meningitis. Malaria, yes, especially during the rainy season. Leishmaniasis, possibly, although in this particular location it's more cutaneous as opposed to visceral leishmaniasis. Typhus, well, maybe the local doctor was right, because typhus is in that part of the world. The enteric hepatitis pathogens, A and E, dengue. This is a landlocked country, so maybe not as likely, although there's parts of it that are very close to the Red Sea. And then you have your virulent RNA viruses, the yellow fever, Rift Valley fever, and Lassa fever viruses. They're all there. Rift Valley is in Ethiopia. So when I examined this patient for the first time, she was actually afebrile. Her weight was just under 7 kilograms. She was quite wasted looking, very lethargic, really kind of a pitiful sight. Basic physical findings: her lungs were clear, her abdomen was protuberant, she had a hepatomegaly, and she had this curious rash I really had never seen before, which was mostly hypopigmented lesions on the lower trunk, perineum, and buttocks. I'll come back to the possible importance of that later. Now, if you're not used to looking at pediatric growth charts, let me just show you. This is the age in months, and this is the weight and length. And what you see is this girl's weight is way down here below the below the 3rd percentile, below the 1st percentile. Now, based on later on, when she lost her primary teeth, I readjusted her age. So I think she actually was probably a bit younger than that, maybe somewhere back in here, but that still put her way, way below her percentiles. So on day 1, when we saw her, we did some basic studies. We did a CBC, and she was quite anemic, microcytic hypochromic anemia. White count was a little bit elevated, platelet counts too. There you see her chemistries. She's hypoalbuminemic. Her HIV RNA that we did was 35,000. Her CD4 was better than what the orphanage had done. It was 1181, so not really in the danger range there. Her chest x-ray, when we first met her, showed mild cardiomegaly, perihilar haziness bilaterally, which our radiologist said was either vascular markings or inflammatory. Okay? So she looked horrible. I told the family, I said, I think she belongs in the hospital. They really resisted because they were still in the process of wanting to bond with the child. And I didn't see any immediate danger, so I said, okay, let's see how it goes for a couple of days, and we let them go home. Before leaving, we put on a PPD. We started her on Kaletra, AZT, and 3TC. We also continued the Bactrim that she'd already been put on in Africa. We started her on Augmentin in case this was pneumonia that we were seeing on the chest x-ray, perhaps causing her fever, and also started her on iron. Asked her to come back in 2 days, at which time her PPD was nothing. Her hemoglobin was the same, and we just said, you know, it's time to put her in the hospital, and let's go ahead and transfuse her. She's not going to do this on her own, and let's work out what's going on. Now, I don't know about you, but one of the first things I wanted to do when we put her in the hospital was to further image her chest. So we did, and here is her chest CT. Anybody want to take a stab at that? Well, I'll use the word miliary. Okay, all these little nodular things looking like little seeds, milia. That's what the radiologist read, in addition to the cardiomegaly. So we did, young children can't make sputum, so if you're going to work up tuberculosis, you have to do gastric washings. So we got that underway. Spinal tap was done, her spinal fluid was normal. Some other imaging was all okay. She had bronchoscopy performed, and we did various things with that. She also had malaria smears, typhus serology, CMV, PCR, stool studies, hepatitis serologies, and an eye exam. So here we have kind of an interesting differential. And we weren't sure what this was. We thought, if it's miliary pattern on chest x-ray, we have to consider it might be tuberculosis, right? But sometimes, especially in immunocompromised people, you can see other things causing a miliary pattern. So could this be mycobacteria other than tuberculosis, like MAI or M. kansasi? Could it be disseminated BCG? We knew that she had BCG, and she's immunocompromised. Lymphoid interstitial pneumonitis is a pediatric condition that occurs in children with HIV infection. And it's usually an indolent condition, but having many times a miliary appearance on chest CT. Malaria and differential, typhus, VZV, CMV, could be a lot of things. What does the audience think that she most likely had? I'm not trying to make this difficult. So her gastric washings and her BAL was nice and positive for Mycobacterium tubercular, acid-fast organisms that we thought was most likely Mycobacterium tuberculosis, and it proved to be. So the first thing I'll discuss in terms of this case is tuberculosis as an opportunistic infection in HIV infection. And if you look at the top map, that's the global distribution of TB. And you'll notice that on the map, which I already showed you, there's a striking similarity to the distribution of HIV and AIDS, meaning that parts of the world that have one are often the parts of the world that have the other. So in Africa, for example, TB is one of the most important, probably the most important opportunistic infections in AIDS. And it works in a couple of ways. First of all, if you have HIV infection and latent TB, you're 100 times more likely to reactivate it than somebody who doesn't have HIV infection. Typical lung lesions, like the apical cavitary lesions, are common in HIV-infected patients who have higher CD4 counts, but atypical presentations are more common in people who are more advanced in terms of their immunologic deterioration. The other way it works is that if you have TB, your HIV goes haywire. So you have higher RNA levels and more rapid progression of HIV infection. So management of TB in HIV-infected patients is the subject of a lot of literature. I'll show you the good parts and the bad parts. The good parts are that it's treated in much the same way that you would treat somebody without HIV infection. So a 4-drug regimen is typical: INH, rifampin or rifabutin, PZA, and ethambutol. Do that for 2 months, and then 4 months of INH and rifampin, or rifamycin, I should say. The one exception, one difference is that for people with very low CD4 counts, you can't use twice daily directly observed therapy. You have to give it every single day. If you have somebody coming from an area where you know there's MDR-TB, or you have other reasons to think you might have MDR-TB, then 2 other agents like moxifloxacin and capryomycin are recommended. If the HIV-infected patient adheres to the TB treatment, it, believe it or not, works just about as well as it does in somebody who doesn't have HIV infection. The problem is the last 2 bullets on that slide, which is that there are major drug interactions and there are overlapping drug toxicities between antiretroviral drugs and antituberculous agents. And the one that gives people the most fits is rifampin, which interacts, as I'll show you, with a bunch of different drugs. So what is typically done and recommended by the World Health Organization, for example, is to use 2 nucleosides as a backbone. Usually that is not a problem. And then in most cases, efavirenz would be the heavy lifting drug. But even that's a little bit tricky because that can interfere with your levels of rifampin if you've chosen rifampin. Efavirenz concentrations are reduced, so you might have to use a higher dose, but you have to be careful on African patients in particular because they metabolize it less slowly. Nevirapine is probably not an easy drug to use. Rifampin you can't use with any of these. There's just too much drug interaction. Rifabutin is hardly ever used in this country, but it's more commonly used in places like Africa. So you could use 2 nucleosides, and efavirenz, not a major problem. And you can also use protease inhibitor drugs. This is all kind of complicated beyond the scope of our discussion, but if you have major interest in this, go to this website. IRIS is an important condition to know about. It stands for Immune Reconstitution Inflammatory Syndrome. So if you have a patient with AIDS who gets started on antiretrovirals and their immune system builds back up and starts to work better, but they have latent infection, and that could be CMV, that could be Cryptococcus, that can be TB, then suddenly you get these weird manifestations, and it's called IRIS for short. So it's a paradoxical worsening, and you certainly can see it in TB. One South African study showed that people started on antiretrovirals who had TB had 30% incidence of IRIS, which is not a good thing to have. IRIS symptoms include fever, worsening chest x-ray, lymphadenitis, and other extrapulmonary findings. So to manage IRIS, number one, if you can, prevent it, which I'll talk about, or if you need to, you can use corticosteroids. Well, that's a double-edged sword too, because the steroids may cause further immunocompromise. So you have two recommendations, one from the WHO and the other from the United States Department of Health and Human Services. WHO says they want to keep it simple, I know, and you may not have advanced technologies to tell you the CD4 count and stuff like that. So they recommend starting heart irrespective of the CD4 count in all patients with TB. The United States says use integrated antiretroviral therapy, so anybody with advanced disease less than 50, start immediately on antiretroviral therapy, but for all other patients, base it on the CD4 and clinical symptoms. So for our patient, we did mostly what the recommendations say. We started on INH, rifampin, and pyrazinamide. So you might say, well, Steve, where's the fourth drug? I don't like to use ethambutol in preverbal children because the main toxicity is ocular, so visual side effects, and if they can't talk to you, they can't tell you they're having it. And then this particular girl just didn't have enough muscle mass to give streptomycin or gentamicin intramuscularly too. So we took a bit of a chance and put her on 3 drugs while we got our susceptible. We knew we were going to recover an organism because we could see it on the smear, so we'd get susceptibilities at some point a few weeks later. And remember the AZT, 3TC, and Galitra, we stopped that because she wasn't that immunocompromised, and said we'll resume that later. Other opportunistic infections in Africa are many times the same as we see in this country with CMV and PCP and all that, but things that are more uniquely associated with Africa are bacterial infections, particularly Streptococcus pneumoniae, malaria, particularly falciparum malaria, and Cryptococcus. So the main emphasis at preventing OIs in Africa in HIV-infected populations involve the use of INH for latent tuberculosis, Bactrim or cotrimoxazole for PCP prevention, pneumococcal vaccine, and anti-mosquito measures. Now this is the ideal, what's actually done because of healthcare infrastructure and just not enough money to go around, is most patients don't get all of that, or some of them don't get any of that. So the next part of my talk, and stop me at any point if you have a question or concern. The next part is just kind of a quick overview of HIV and AIDS in Africa. So sub-Saharan Africa is home to about 10 million people. I'm sorry, I said that wrong. It's home to 10% of the population of the world, but it's home to 70% of HIV infections in the world. Currently, there are about 23 million people living with HIV. In the calendar year of 2010, about 1.2 million people in this region died of it. 4 countries have an adult prevalence of greater than 20%. That includes Swaziland, Botswana, Lesotho, and Zimbabwe. In Ethiopia, which is a little bit north of the epicenter of HIV/AIDS, the rates are less, about 4.4% in that 1 year where I could find decent, believable numbers, maybe more than that now. And that's mostly concentrated in Addis Ababa, less so in the rural areas. Different parts of Africa have kind of different dynamics going on. So Kenya and Zimbabwe have already peaked, it seems, and are on their way down. Others, like West Africa, Ghana, Cameroon, are still on the rise. Over 50% of cases are in women. 10% of cases or so are in children. And the average life expectancy in sub-Saharan Africa has gone down over the years and is now 47 years. If you looked at pre-AIDS trajectories of life expectancy, it would now be about 62. So about 15 years of life has been lost in the population because of this. Families lose their income earners. They're too sick to go work out in the field. Orphans are left behind when their parents die. It's had a huge economic impact in places like Botswana, where they have a lot. Big economic strain on the healthcare sector, of course, and a lot of us healthcare workers are now becoming infected. Prevention has to do a lot with education. So a lot of countries have been more active in this than others, but you find billboards along the road. Condom use has been stressed and is now taking off more in the last 10 years or so. So, for example, where we have 10 for every man in 2004 compared with 4.6 in 2001. Used correctly and consistently, condoms reduce transmission of HIV by about 85%. They're also very, very cheap. Unfortunately, there are a lot of social and cultural barriers we have to overcome, so condom distribution, condom sales have to be accompanied by counseling and testing. Found this from a shop in Central Africa. Can you spot what's going on there? Okay. As far as pediatric HIV/AIDS, as I said, about 2.5 million in sub-Saharan Africa. Untreated, the risk of maternal to child transmission is between 20 and 45%. Some of that is a result of breastfeeding. In 2006, preventive drugs reached mothers about 31% of the time in some areas, as low as 7% in other areas. This is real easy and real cheap. 2 doses of nevirapine given to the mother has been shown to reduce dramatically mother-to-child transmission at a cost of a couple of dollars. Well, for treatment, we've got a lot of work to do. Currently, only about 1 in 5 or less of infected persons is receiving antiretroviral therapy. South Africa, which is the richest country in sub-Saharan Africa, has it up to about 33%. And there are all kinds of barriers, as you might know, including the cost of the antiretroviral drugs. Although, having said that, a lot of the generics are relatively cheap, and a lot of the drug makers have forked over at no cost supplies of antiretrovirals to certain governments. And then the healthcare infrastructure has just prevented any kind of robust effort at making this happen for a lot of the countries. One study done by Côte d'Ivoire showed that if you just use prophylaxis, like I said, so you give TB prophylaxis, malaria prophylaxis, etc., that costs about $240 per year of life gained. If you use antiretroviral drugs and prophylaxis together, that costs a little over $600 US for each year of life gained. If you use a CD4 count, which there are point-of-care CD4 counts that you can use in places like this, you can direct your antiretroviral therapy for where it will do the most good, but that raises the price up to about $1,180 per year of life gain. So that's a lot of money. That's many times the health expenditure per capita of a lot of these countries. So moving forward, lots to do. There's been an increase in funding. I think probably the best thing, one of the best things to come out of the Bush administration was PEPFAR, and I think it really, really has done some good. Commitment on the part of the governments of Africa, reducing stigmatization, particularly in women, and getting women the treatment they need to help not only them, but to prevent perinatal transmission as well. Something else you may not be aware of, which is HIV subtype diversity. So here's a nice article, if you really want to delve deep, published in New England Journal in 2008. Turns out HIV, like other RNA viruses, is a very sloppy replicator. So it makes mistakes all the time, and that leads to mutations. So back however long ago, 100 years or so, when simian immunodeficiency virus kind of made the leap to become human immunodeficiency virus, you have a family tree develop with lots of limbs on it. So these limbs are called subtypes, and you can see all the ones that have been identified to date. And here is the geographic distribution of HIV subtypes. And what you see in lavender in North America is what we have exclusively, which is subtype B. And throughout the rest of the world, you have a little of this and a little of that. The irony and the tragedy is that only about 12% of global infections are due to the type that's most studied, which is the one that we have in this country and parts of Europe, which is subtype B. So a lot of what we knew for the first 20 years was really studying subtype B. But this is important for a couple of reasons. At first, people were worried, do non-type B clades respond as well or respond differently in some way to antiretroviral therapy? And the answer is not usually. But there's this phenomenon, which is the third bullet, which is really interesting. I don't know if you've heard of GB virus C. It used to be called hepatitis G. So GB virus C is a ubiquitous virus in parts of the developing world. It causes a minimally symptomatic infection in humans, but you have a latent infection. And people who are latently infected with this seem to have resistance to HIV. So they get HIV, but they don't progress as rapidly. So there's a protective effect of this, and this also affects how these patients respond to antiretroviral drugs. I think in the interest of time, I'm going to skip a couple of slides. So back to our patient. We started her on anti-tuberculous therapy, pat on the back for us medical types. We figured it out, and she's on the way to recovery, right? So she continued to have poor weight gain. We actually had her seen by gastroenterology because she was clearly malabsorbing. She had recurrent skin infections due to MRSA. We never knew if this was MRSA that she brought from Addis Ababa or she acquired it in clean little Delaware. And then she developed recurrent bouts of wheezing. In fact, she was hardly ever wheeze-free, and she got sick enough a couple of times to be in the hospital. One chest x-ray showed hyperinflation and some mild airspace disease. And then we started to notice, just on routine CBCs that we were getting like we get on everybody, she developed pretty significant eosinophilia. And then her maximum was a white count of 23,000 with 51% eosinophils. So good old Steve, so what is going on here? Didn't expect that. By the way, here's another kind of classic reference. This is from New England Journal, 1998, on eosinophilia, if you ever need to find out more. So I figured, well, of course, this is a parasitic infection, right? But back to the article. These are all of the main categories of etiologies of eosinophilia. But if you look at the top line, infectious, which is the biggest one globally, it's parasites, particularly helminths, that are the most common trigger for eosinophilia. So I figured that's what's going on, so we ordered a bunch of stool over parasite exams. They all turned out to be negative. We ordered serologic tests for Toxocara canis, Strongyloides, Trichinella, and Schistosoma, and they turned out to be negative too. And I'm kind of worried that I'm missing something, and we talked to a couple of experts, and we decided to just empirically give her a trial of antiparasitic therapy, so albendazole for 3 days. But it didn't seem to do good. And then I did what I should have done at the beginning, which is to call the CDC and talk to the parasitic diseases branch. If you ever have a parasite or think you have a parasite, call these people. They were incredibly helpful. And they said, first of all, don't believe any of those serologic tests because most commercial labs don't know how to do them. It's a learning point for me. So we started to dig deeper. So these are all the parasitic diseases that you can find in Ethiopia. Well, some of them we can cross off the list right away. Malaria, leishmania, those are unicellular parasites. They don't cause eosinophilia, so cross those off. Enteric infections, well, there's amoebiasis. That's also unicellular. Cross that off. Giardia, cross that off. The rest are worms. Ascaris, lumbricoides, Strongyloides, hookworm, whipworm, and tapeworm. So at the behest of the CDC, we repeated serology for all those worms, sent to the CDC, and found a strongly positive result for, which one? Give you a hint. So that's Strongyloides stercoralis. My first encounter with Strongyloides, just by way of total digression, I was a first-year fellow in infectious diseases, and I was in the micro lab, and a microtech shouted out, and everybody came and gathered around, and everybody was looking at this blood agar plate, and there were little tracks all around the blood agar made by a Strongyloides larva. And that was in a patient with a renal transplant who was immunocompromised. So, not to give you the full and incredibly complicated life cycle of Strongyloides, but its two main targets when it infects human, it often is acquired as a result of penetrating through the skin, and then it goes in the GI tract. and then matures, and they've got rhabditiform larvae and filariform larvae, but in the GI tract, the rhabditiform migrates out, gets in the circulation, can go to the lungs, and sit there and go to town in the lungs. So it's mostly GI tract and lungs that are involved in human strongyloides, unless you have significant problems with your immune system, which you can get what's called strongyloides hyperinfection syndrome. And that's what our patient had. So here you have accelerated autoinfection, going back to the life cycle, autoinfection, where it gets to multiple tissues and organs. And untreated, this has mortality approaching 90%. So it goes to gastrointestinal sites, the pulmonary involvement, which can be fatal, leading to respiratory failure. Gram-negative sepsis. Now, why would that happen? Well, because when the worm migrates out of the intestinal tract, it takes with them what? Gram-negative bacteria. So it gets in the circulation, people get gram-negative sepsis. It can get to the meninges, and either the worm itself or the gram-negatives that were brought along by the worm can cause meningitis. And then you can get these very interesting cutaneous lesions, which I believe that our patient had when we first met her. And they tend to be sites of reinfection. So here's a diapered child, and they're mostly in the diaper region, and I think that's what was going on. So had we been kind of tuned in at the beginning, we might have made that diagnosis faster. Treatment of strongyloides is ivermectin. That's the treatment of choice. You may recognize ivermectin if you have pets, because it's frequently used in veterinary medicine in the United States. It's also used for a variety of parasitic diseases across the world. You give 2 days, wait 2 weeks, and give 2 days again. Relative contraindications include concomitant loa, because if you give it, that makes the loa mad and they migrate. And then pregnant and lactating women or persons weighing less than 15 kilograms. Our person weighed about half that, but we thought that we needed to treat. Albendazole is an alternative. Remember, we'd given an empiric course of albendazole, but we gave it for 3 days. You have to give it for at least 7 for strongyloides. So our little patient got the ivermectin and she got better. I truly believe that more of her problems in her first year after she got here were due to strongyloides than her disseminated tuberculosis. After she finished her anti-TB therapy, we put her back on Kaletra, AZT, and 3TC. Now, anybody in the audience who's sophisticated about HIV care would say, well, it's an antiquated regimen, why'd you use that? Well, in our defense, in 2008, that was probably still the standard for pediatric patients. And a lot of the drugs that you're used to for adult patients are not available in liquid formulations for children. So she was put on that and has stayed on it to this day. Her viral load went to undetectable within just a month or two and has stayed undetectable since. Last time I saw her, her CD4 was 1,992, and she sang me the sweetest little rendition of America the Beautiful, which I captured, but her mother said, sorry, you can't play it to an audience. She's done remarkably well. She's, I'm pretty sure, smarter than her classmates. She's done beautifully in school. She's now in the 2nd grade and doing great. And that's all I prepared, except to say apologies to Ian Fleming and Sean Connery in the naming of my talk. But I figure we've got a good 10 minutes left for questions, right? Questions, comments? LBJ.
So Steve, you saw in the 2nd day that you came to this country, and then you had this diagnosis down the line. How many days, weeks, months between?
Oh, well, let's see. It took us about, within a week we knew she had TB. But the strongyloides, that was August of the following year, so that was 8 or 9 months after we first met. Yeah, a good question. I should have put a timeline there. Carla?
Did you repeat her vaccine titers?
Oh, yes. And a pediatrician who you know quite well became her PCP and got her, did all of the foreign-born adoptee stuff, on top of what we did, and got all of her immunizations up to date, so she's totally good in that regard. I know that's something you do a lot of. Oh, it wouldn't surprise me if she wasn't. Yeah. So on those vaccine records from orphanages, look for signs of fraudulent documentation. The biggest one is if they're always done on the same day of the month. So it's June 8th, it's August 8th, and it's October 8th. You know, that's that kind of thing. Or look for things that are obviously, it may be all in the same ink or all in the same, you know, scroll. But a good point. Omar.
Question about breastfeeding. You mentioned that significant amount of HIV is required while breastfeeding. The WHO recommendations for breastfeeding by HIV infected mothers is that in fact continue in situations where you have ARVs available. Do you think hers was one of those situations where would this be considered an ARV-rich area, or would you have recommended alternative feeding?
So you make several very good points. So we learned relatively early on that the benefits of breastfeeding early on outweigh the risks. So if you have about a 15% attributable risk getting maternal-to-child transmission from breastfeeding, that probably is better than getting a fatal gastroenteritis that breastfeeding might have prevented. If you have antiretrovirals, it makes it all the more advantageous to breastfeed. To answer your question, I don't think that this mother, as far as I could tell, this mother of this baby never got antiretroviral treatment. And Ethiopia it's not a resource-rich country where I would even expect that to be available. But, yes, Larry.
At what point do you think about modernizing breast? How do you see AZT?
Well, I'm a little old-fashioned. I'll tell you why. In the early days, treating children with AZT, it was the only thing we had for a while, of course. But up to 70% of children will get central nervous system involvement. So they get the HIV dementia, leading to wasting and the whole bit. And one advantage of AZT is it crosses the blood-brain barrier better than a lot of the other antiretrovirals. So I still think it plays a role. And unlike adults, where AZT tends to be so toxic and people don't feel good and they can get anemic and so on, kids tend to tolerate it better. So I still think it's part of our armamentarium. Kaletra is not the protease inhibitor of choice anymore because of lipid issues and other things. So she should be modernized at some point. So it's been a number of months since I've seen this kid. She's so smart, she can probably swallow pills by now, which will open the door to a lot of other treatment choices for her. Yes, Chris?
So first of all, that was excellent. Thank you. And good case and then good institution of public health and information on Ethiopia. So that second thing. I know some people in the audience have read this, but Cutting for Stone by Abraham Verghese, who actually did some training in Ethiopia, but he's a physician, I believe a surgeon at Stanford. So his book takes place in Ethiopia and talks about their health system and culture. And it's, I'm pretty sure everyone that's attending this conference would enjoy that book. So I wanted to say that. And sorry to keep talking, but then this is my question.
Before you get to your question, let me point out that a number of years ago, this is probably 12, 15 years ago, Abraham Verghese gave the keynote lecture at the Holloway Infectious Disease Symposium.
Excellent. So I thought of at least 5 questions, but I'll limit it to one. Realistically, in 5 years, where do you think our country, so just specifically the United States, will be with HIV as a public health issue compared to now? So 2014, so where will we be in 2019 in terms of, our screening, our detecting, our treating?
Well, let me start by saying our current president has made that a priority, and bravo for that. I don't know the numbers of where we're going to be 5 years ago compared to now, although I think we have several important organizations pushing us to move in the right direction. And I know you know the answer to this, but 2006, the CDC said, you know what, everybody between 13 and 64 years of age who enters a healthcare setting, no matter what they come in for, should get screened for HIV. And some people, the high-risk people, should get screened often, like every year. The American Academy of Pediatrics, as you know, said that every child 16 and older should get screened if they come from an area where the prevalence is 1 in 1,000 or greater. Laws are changing in this country. So year before last, 3 years ago, it changed in Pennsylvania. 2 years ago, it changed in Delaware. So that the requirement for informed consent and all that other rigmarole that we used to go through when we first wanted to test somebody for HIV infection has been rescinded. And that's going to allow, and I'm going to ask Chris to expound on this himself, that's allowed organizations to go forward with screening adults and adolescents for HIV infection. I think there's a better understanding in this country, and I think it's getting out to the general public that there's a lot of HIV out there, and you know the figures. 20% of people in this country who have HIV do not know their status, and those 20% give rise to 50% of new cases. So you say that to a group of lay people, that kind of jars them. That's like, my God, we need to do something about that. So I think, but a lot of forces are coming together, I hope, in an enlightened public in particular, that will allow us to do a lot better job. Would you like to say kind of what you've been up to?
Sure. Not on my own, because you've been helping as well as some other folks. So in our Wilmington clinic, we have a rapid HIV test, which is somewhat new technology in the last several years, that basically uses saliva as the sample to do an HIV test with results in 20 minutes. And we've been doing it in our adult population for about 3 years because of Dr. Tesla's work with her grant that she got for our clinic. And starting, hopefully, in 1 or 2 weeks, we will be rolling out the same thing in our pediatric population at Wilmington. And we have the technology, we have the people, we have the tests, but in the pediatric population, it requires a bit more structure and organization, such that you need to know what to do if there's a positive test. Not to say that you don't have to have a plan with an adult, but there are other social issues that we had to organize ourselves with. So starting very soon, we'll be doing that. And fortunately, and I'm glad to hear this, in the area, we're not unique in doing this test and offering it and using it routinely in the pediatric population. The Jessup Street Clinic is doing it. Thomas Jefferson has several of their clinics doing it. So hopefully, sort of answering my own question, maybe that will become the norm, that not just clinics here and there are using the rapid test routinely, but almost all clinics are.
Well, that's, perhaps the most important thing that we implied but didn't say outright was that linking testing to treatment is the key to managing this condition. And that's what Obama's agenda really set as a priority. So it's screening them, identifying them. We know that when they're identified, their risk-taking behavior is reduced. When you put them on antiretroviral therapy, their infectivity to others is reduced. So this is a major public health priority. It's a little different in this country than it is in so many other parts of the world, for which we should be thankful. Any other questions?
Great.
Thanks.
Thank you.